Good afternoon, everybody. Welcome to another fantastic Grand Rounds. Today we have a Grand Rounds presentation by our chief residents at the VA, Dr. Alejandro Rodriguez, Dr. Nabiha Khakoo, and Dr. Jose Noy, who's one of our fantastic quality improvement and patient safety chief residents. So this is a multidisciplinary presentation. We're really thrilled for that to have them present. And without further ado, take it away.
Okay. Hi, everybody. Thank you, Dr. Brown, for the introduction. So again, my name is Alejandro Rodriguez, and I have my co-chiefs here with me. We're going to go ahead and get started. This is our second clinical problem case conference of Grand Rounds this year. This one will have a slightly different focus to the one that we did last time, looking more at patient safety and improvement. So none of us have any disclosures, unfortunately. And so we're going to go ahead and starting off with an introduction about what the purpose of this session is. So we want this to be a safe environment for everyone here, for faculty, trainees, and staff, to help us identify areas of improvement, looking at how we can promote professionalism, ethical integrity, and transparency as we go through this complex case and think about how we can improve patient care based on the events. So we want this generally to be a forum where we can teach curriculum around quality improvement. We want it to be an environment where we can promote just culture and a blameless environment. And lastly, to foster a climate of openness as we discuss frankly about medical errors. And more specifically, after today's session, we're hopeful that you will all be able to recognize and assess a patient presenting with clinical signs of a severe soft tissue infection using a multidisciplinary lens and the input from our special discussants. We want everyone here, to be able to stratify patients requiring urgent surgical intervention for skin and soft tissue infection. We want you to be able to analyze what patient factors contribute to your choice of empiric antimicrobial therapy for this diagnosis, and to differentiate patient-level, individual-level, and system-level factors that ultimately contribute to quality of care. And we'll use a root cause analysis at the end of the case. So we're going to go through the facts of the case and again involve the special discussants at different points as they were involved in the actual events of the case. So we're going to start off with the chief complaint, and I hope that you note that we're using the dates where the actual events transpired, and hopefully that can be a point of reflection as we go towards the end. So without further ado, we have a 75-year-old gentleman who presented to the emergency room for severe pain in his right leg. Going into more details in terms of the history of present illness, he was brought in by emergency medical services again on December 30th. He had right foot and leg pain. Initially, he had come in a couple days earlier on December 25th with what was just right foot pain at the time. He was noted to have a lateral heel abrasion, although the patient didn't really recall any trauma to the area. He was treated with steroids and analgesia and discharged from the emergency room, but subsequently did return on December 28th, now with persistent pain, but also swelling and erythema of the area. Now, at this point, podiatry was consulted for this visit on December 28th. There was some workup that was obtained, including x-rays of the foot, which were negative for any acute pathology. There were non-invasive vascular studies that were obtained, which demonstrated some mild peripheral arterial disease and no evidence of any deep venous thrombosis. At that time, the patient was again discharged, this time on doxycycline for a presumed cellulitis. And leading to December 30th, the patient noted that he had progressively worsening pain that now extended proximally to the lower leg. The wound looked larger per the wife compared to December 28th. And since then, she had noted that her husband was also intermittently confused and not really eating or drinking very much. So some background medical history for the patient. He had a history of coronary artery disease, for which he had a bypass graft surgery in 2015, some strokes in the past for which he didn't have any residual deficits, chronic kidney disease, stage 3B by GFR, some type 2 diabetes, and chronic peripheral neuropathy involving the lower legs, although this pain was much more severe and on top of that. He had a history of paroxysmal atrial fibrillation and sick sinus syndrome, for which he had a dual chamber pacemaker placed in 2022. And hypertension as well. In otherwise surgical history, notable for a right hallux amputation many years ago, and no contributory family history. Continuing in terms of other additional history, the patient had no allergies. In terms of his social situation, he lived with his wife and also had children and grandchildren at the home. He was a retired Air Force veteran and former police officer. Denied alcohol, tobacco, or illicit drug use. And in terms of medications, you see here a list, the medications that you would expect someone for his comorbidities. Going back to the ER presentation on December 30th, in terms of the patient's vital signs, he was afebrile. His heart rate was on the higher end of normal at 91, respiratory rate of 18. He was normotensive with a blood pressure of 107/58, and he was saturating 95% on ambient air. On his exam, the patient was ill-appearing, some mild distress due to pain. His cardiovascular and respiratory exam were within normal limits. His abdomen was benign. When they looked at his extremities, so his right foot on the side of the posterior ankle, you could see the wound. You could see that the surrounding skin was macerated. There were some signs of ecchymosis. The wound appeared superficial, some areas that looked violaceous and dusky. There was no drainage or malodor appreciated, and they did make note of the prior right hallux amputation. Neurologically, the patient was awake and alert, but only oriented to person and place. He was not sure of the time. He had some waxing and waning attention during the interview, primarily kept his eyes closed throughout, and as the wife presented much of the history. He was moving all of his extremities and following commands, but did have some diminished sensation to light touching the bilateral feet. And here we have an image. So this is from December 28th, so 2 days prior to the patient's current presentation. So already you can see that he has a wound that's about 3 centimeters in the posterior aspect of the ankle. There's some, thank you for dimming. So there's some areas that look violaceous, perhaps even some areas that look dark enough to appear somewhat necrotic. And the swelling and erythema can be appreciated even from the lateral aspect. And this is, we'll have more pictures as we go along, but this is the anterior aspect. This is on the day of presentation, so you can see that by this point, the areas of duskiness and violaciousness extend to the anterior aspect of the ankle. And compared to the left foot, the right foot is significantly swollen. In terms of the initial laboratory workup, we highlighted here some of the pertinent findings. So in terms of the chemistries, you can see that the bicarbonate was lower at 17. The BUN and serum creatinine were markedly elevated at 109 and 3.8. The patient's baseline serum creatinine was between 1.8 to 2. Somewhat hyperglycemic on presentation. The lactic acid was elevated at 3.7. And you see some elevations in the creatine phosphokinase and the AST. And
back to the physical exam, I just want to see your documentation of the arterial pulses.
No, it was, you're correct. It's not noted here, but the pulses were palpable on the left, and he had on Doppler the pulses were present on the right.
Yeah, it's important to document that, right?
Absolutely. Okay, so again, the appearance of the foot on the 28th and the 30th. Mm-hmm.
Wait a second, Dr. Lichtenberg. Let me give you the microphone so the people online can hear you as well.
And it's just to highlight the importance of calling things by their name. So on the 28th is the time when he was discharged on doxycycline for a diagnosis of cellulitis, isn't it?
Correct.
With that picture. Can you go?
Yes.
Exactly. So by definition, this is not cellulitis. So please learn that when you are calling something cellulitis, you are not seeing disruption of the skin. So that's the first concept that we have. And if we don't have the picture, but you're calling something cellulitis, doxycycline is not the first antibiotic choice. Stop thinking that MRSA is everywhere. The main culprit for cellulitis, it's going to be streptococcus or MSSA. And doxycycline is not a good antibiotic when you're thinking about the streptococcal infection. So just for the concept of definition of when we're giving definitions, and that will be better called as necrotizing infection, ecthyma, but not cellulitis.
Thank you, Dr. Lichtenberger, for your input. So as we go through the case, we're like I said earlier, we're presenting the facts and events as they transpired, and we'll talk about as we go through where things could have perhaps gone differently. So going back to the labs, so the patient did have an elevated white count at 15.9 with neutrophil predominance, but otherwise his hemoglobin and platelets were preserved. And it is at this point in the case that podiatry was consulted. And here to give the podiatry perspective, we have Dr. Rafael Laposte. Dr. Rafael Laposte is a board-certified podiatrist at Jackson Memorial Hospital and South Baptist Health Systems. He completed his education at the New York College of Pediatric Medicine and residency at Palmetto General Hospital. His specialties include diabetic foot wounds, sports injuries, foot and ankle trauma, and advanced limb salvage techniques. He is a co-founder of Peak Podiatry Specialty Clinic in Miami Lakes. Dr. Laposte prioritizes patient-centered care and preventative techniques to ensure holistic foot and ankle health. Please help me welcome Dr. Laposte to the podium. Once again, Dr. Laposte. So, Dr. Laposte, our question for you is, when a patient presents with a foot wound, what is your initial framework for determining surgical versus non-surgical management, and what level of surgical intervention is required?
The first thing is obviously if there's any type of risk, limb salvage is the first thing that comes to mind. So if the infection is increasing the level of risk of a possible amputation and of obviously further complication, right? It's very easy, it may be overlooked, but it's very easy to go from what was perceived as a semi-simple cellulitis, as Dr. Lichtenberg specified, to a full-blown septic event, and this patient progressed on, as we'll find out. But the first process is trying to assess how deep is that infection, and to try and basically cut down on the level of intervention, because you usually will have some level of intervention, but the key thing is, okay, we're catching it now. Where can we intervene so that we can stop that progress? What was your other question? Okay. Yes. Perfect. Okay. All right. So there's a lot of stuff on the screen. So by all means, read it. I don't know if this is going to be available for you guys to review later on. There's a lot of stuff on there, and I'll just try to briefly go over it to give you kind of like the Cliff Notes version of what I've put on. And the main thing is, number one, like as we mentioned, based on the question, is how are we assessing these patients if we have a problem before us that requires surgical intervention? So you're going to put that into three categories. I'll start on the opposite, from right to left. Non-surgical candidates are things that, if it is a cellulitis, it's within a controlled measured area. Per the infectious disease guidelines, it would be less than 2 centimeters of cellulitis. The patient has adequate perfusion. There's no bone involvement, and bone involvement can be questionable, whether it's just something that's seen on radiograph, even though you don't have an open wound, because obviously we can have other sources and other ways of having latent osseous changes on X-ray. But you want to make sure that whether there's actually exposed bone or even probing to bone, what level of involvement is it the pure chronic or more acute? And the patients, our patient demographic, as most of you probably have already encountered, is kind of difficult, and that works against what we're trying to do most of the time. So whether the patient is reliable with offloading, they're managing their sugar, they're following up with their primary doctor, and they're taking their medication. Those things are all important. And a clean granular wound, right? Just the look of a wound can give you a very distinct, very clear opinion or idea of what you're dealing with. If you get a nice beefy red granular wound and no other associated changes, then that it's a rough estimate to say, okay, you know what, this wound is pretty stable, probably chronic. This didn't happen yesterday, and that will give you a better angle on how to manage that. So moving on to more urgent findings, now you're looking into where you're having a gross infection. There's an abscess that's possibly either clinically notable based on palpation, if you have some fluctuance or even some crepitus, where it's like that crunchiness, like what a tissue paper, like from a gift bag, you kind of feel that, even if you can't necessarily hear it, but you kind of get that sensation when you palpate the tissue. And obviously an either clear abscess where you have an abrupt enlargement of the soft tissue, and you can assess that pretty clearly. Probing to bone has a high prevalence wound. There's been literature that refutes that probing to bone actually is as diagnostic for osteomyelitis and other infections. But obviously, if the bone is exposed, we know that you are automatically in a higher category for worse infection. So it's still something to consider to elevate that patient to a more serious finding. Failure to improve, right? If this patient comes in and says, "Oh, my primary doctor sent me in, and they started me on antibiotics, and it hasn't gotten any better," that's already an indication that sending that patient back out on more antibiotics is probably not going to make much of an impact. So we want to be very careful with that, because we get a lot of those patients through practice. They're primary, or especially in South Florida. My cousin is a doctor somewhere, and they told me I should go get this, and they start themselves on whatever antibiotic for whatever amount of time. And obviously, critical limb ischemia, that's obviously significantly more important than some of the other more local infections that we may have to manage, because that can progress rapidly, right? So that complicates an infected wound, because any intervention can actually basically maximize the impact of that infection when you're going into and debriding or doing any type of procedure in an area that doesn't have perfusion. So you have to be very careful with that. And obviously, emergency presentations. Now we're talking about, you have to go to the OR now, right? For those who are in rotations and surgery, stuff like that, you have to categorize these with a NEST score. So these are like NEST 1 and 2. These are critical patients that if you don't intervene, as I was talking with Dr. Kang briefly before we started, it can go from having a patient having lost a toe to losing a limb. It really can be that dramatic. Those changes that you saw in the pictures within 2 to 4 days from the original presentation in an acute infection with necrotizing fasciitis or a wet gangrene can change in a matter of hours. So those are the ones that are obviously the ones we have less room for error, and we need to be very critical on that assessment, that we're not dismissing those as something simple. Wet gangrene, once you see it, necrotizing fasciitis, once you see it, gas gangrene, once you see it or smell it, it will stay with you forever, certainly for a few days, because that smell, and you won't miss it the next time. So those are things that you really want to kind of put in your not in your back pocket, in your chest pocket, as far as when you're assessing these patients and their presentation. So choosing the level of surgery, from my perspective, obviously we want to focus on obviously stabilizing the patient, but we want to also address that from a limb salvage situation, right? I've seen patients where, unfortunately, where I've been consulted, let's say the patient comes in with some type of infection, and in haste, which is a great approach, the ER has consulted myself, and they consult vascular, and they'll consult ACS, and they'll consult everybody else, general surgery, and come in to see the patient and find out that the patient came in, let's say, with a midfoot abscess, maybe some gas on x-ray, and patient ended up with a BK, right? So we don't like to make those drastic limb salvage attempts. Sometimes it's necessary if the patient is progressing septically and we're concerned for their life, but we have to kind of have a stepwise approach on how we can try to control that infection locally. So bedside I&D procedures are your number one. And patients come in readily with these type of infections. You have it from your drug user patients to your diabetics that are walking around barefoot to any number of situations that can present with a localized abscess, and you can manage those in the emergency room or even in clinic. To maintain and kind of stabilize that situation. Or debridement and washout, that's where you have a deep space involvement. So if you have assessed whether with an ultrasound or any other imaging that you have a deep abscess, now you're concerned with whether that infection is, it can be extending down to bone, even if there's no evidence on imaging studies or clinically there's no probing to bone. You should automatically start assuming that there may be some ascension of the infection through your tendon sheaths, which can also spread rapidly within the extremities. So that's where those cases you would want to take to the OR and have a formal washout. Again, that doesn't exclude those patients from getting a bedside I&D to kind of make sure that you can stabilize them and try and decompress the situation, but they would probably need to be admitted and move on to a further debridement and washout. Amputation, obviously, whenever we can try and salvage a part of the foot or the limb, that's our goal. But we also have to keep in mind, from a podiatry standpoint, is how much of a functional limb are we leaving this patient with? Some patients are dead set that, you could have 4 digits that are necrotic and it's extending to the midfoot, and say, hey, listen, we're going to do a transmetatarsal amputation, where you take off all the metatarsals, and they say, no, I want you to leave the pinky. Well, that pinky isn't going to do anything for that patient, right? So you have that battle, but we want to preserve the limb, but it has to be a functional limb. And sometimes, even though the infection, or sometimes the location of the infection, or the devitalized tissue and bone that's affected, precludes us from maintaining that limb salvage. Sometimes we end up having to defer to a higher level amputation, because we will leave the patient with essentially a non-functional limb. So TMA midfoot amputations are very common. Patients can be extremely active. I have patients that work construction. They have TMAs and show parts, which are about a 3/4 foot amputation. A TMA is about a 1/2 foot amputation. And so patients can be very active. They're concerned, and they tell you, no, but I'm not going to have balance. Not the case. There's things that can help assist that afterwards, but those are very powerful procedures that can maintain the patient's life and their level of activity. And obviously, major amputations are BKs and AKs, that's just beyond anything that can be salvaged based on tissue loss, bone, perfusion, and those other aspects. Yeah. So quickly, basically, you want to make sure that you are assessing the patient not singularly. You don't want to pigeonhole yourself, say tunnel vision. Ideally, it would be every one of these patients that we're even considering falls into this category. All of us would be seeing the patient. Infectious disease and vascular and podiatry would be walking hand in hand down the ER. That doesn't happen, but we have to basically help each other out, and we do see that. We consult each other when we assess these patients that are coming in, where they could benefit from each other's assistance. So basically, it's just never underestimate the presentation of an infection. Make sure that you're taking into account indicators of possible vascular compromise, and correctly assessing whether it is an infection, whether it's a chronic wound, or a wound that can have more underlying critical findings that need attention more immediately. Thank you, guys.
Thank you so much, Dr.
All right. Thank you so much, Dr. LaPoste, for that amazing contribution to the conference. So just continuing with our case, on the same day of admission, podiatry was in fact consulted in the ER, and they did perform that initial wound dressing. They did recommend to start broad spectrum antibiotics, as well as a vascular surgery consultation for a suspected ischemic wound. The patient was subsequently admitted to the medicine service for further management of sepsis in the setting of the skin and soft tissue infection. And per the sepsis protocol, they received an IV fluid bolus with subsequent improvement in the lactic acid down to 3.1. As part of that protocol, blood cultures were also obtained, and as we mentioned, the antibiotics had been initiated by that point. So it's now that we have Dr. Naichin Kang, who's going to be providing our perspective for the vascular surgery side. Dr. Kang is a board-certified vascular surgeon at the University of Miami and Jackson Memorial Hospital Health Systems, as well as the Miami VA Medical Center. She completed her education at Albert Einstein College of Medicine and her general surgery residency at Hofstra Northwell School of Medicine. She then completed her vascular surgery fellowship here at the University of Miami, and she currently specializes in the treatment of carotid artery disease, complex aortic aneurysms, peripheral arterial disease, renal and mesenteric revascularization, and vascular trauma. She is also widely published in several peer-reviewed journals, including the Journal of Vascular Surgery and the Annals of Vascular Surgery. Please join us in welcoming Dr. Kang.
Thank you very much for the invitation.
Yeah, sorry. So our question for you is, what are the most important considerations in deciding surgical management and timing of intervention for a complex skin and soft tissue infection?
Thank you. I have a few slides to share. I will try to be as fast as I can. So the definition of necrotizing soft tissue infections: rapidly progressing skin and soft tissue infections that leads to extensive tissue necrosis affecting dermis, epidermis, often also involving deeper layers of fascia and muscles, leading to systemic illness, morbidity, and mortality. This necrotizing soft tissue infection actually replaced necrotizing fasciitis, a term originally used in 1950s to include a broader range of cases in which necrosis extends beyond the fascia, involving the muscles and neighboring tissues. Necrotizing soft tissue infections include necrotizing forms of fasciitis, myositis, and cellulitis. Necrotizing fasciitis is an uncommon, rapidly progressive, often aggressive bacterial infection causes extensive necrosis of subcutaneous tissue and fascia. And estimating the incidence is actually a challenge, and it's relatively rare. The reason is a challenge because there's no standardized reporting mechanism, and there are so many different terminology to describe it. We talk about this case as necrotizing fasciitis, one involving a fascial plane. We have fourneous gangrene in cases affecting genitalia or peritoneum, or we have gas gangrene when tissue gas is a prominent feature on imaging or physical exam. So incidence in U.S. is about 8 to 10 cases per 100,000 individuals, and there is actually a correlation between this and the warmer climate, according to some epidemiology studies. Classically, patients with necrotizing fasciitis exhibit a triad of pain, swelling, and erythema, which is a clinical sign also seen in non-necrotizing soft tissue infection. So not everything is necrotizing fasciitis. Actually distinguishing the two is not that easy. However, treatment strategies prognosis vary differently. In necrotizing fasciitis patient, the pain tends to be out of proportion to the physical findings, and patients might encounter sensory loss at the site of involvement, which is the case. It was very difficult to examine the patient when I first met him on the day of surgery. You can barely touch him. Can be distorted by painkillers, however, also can mask the characteristics of this crescendo kind of like pain. The patient with diabetic neuropathy also might not really have pain out of proportion because they have neuropathy at baseline. Within 1 to 2 days of infection, the bullae and vesicles may begin to form, accompanied by serosanguinous leakage and followed by skin necrosis and crepitus. Bullae formation is not in everyone. It's about 40% of the case, 45% of the case. Skin necrosis and crepitus occurs less frequently, only 23% or 4.9%. So not everybody has crepitus. The symptoms really varies. Depends on, the bacteria. Bacteriology. As the disease progresses, the virulent pathogens and toxins are released into the bloodstream and leading to a systemic toxic reaction, may manifest as hypotension, fever, ultimately multi-organ failure, which is what this patient had. There's no gold standard lab test for diagnosing this. Elevated lactate level was found to be independent predictor for amputation and mortality in this patient especially. Increased procalcitonin emission was associated with progression to septic shock, and there are many markers, biomarkers, or scoring system have been studied with different modification, with different range of numbers you are looking at. However, there's no, for example, the Dr. Lepose's presentation also mentioned the scoring system. A score of 6 or above higher is strongly associated with necrotizing fasciitis. Imaging studies. MRI has emerged as a preferred modality to diagnose necrotizing fasciitis because I actually can see the different tissue layer. However, it's a longer study, not really for emergency. CT scans are generally preferred as the initial imaging choice in emergency situation due to the broader availability. However, the diagnostic value for CT scan is more useful in the abdominal peritoneal situation that you see air, you see a lot of soft tissue. However, it's less useful for the limbs, right? You're looking at the limbs versus an abdomen. This could be everywhere. X-ray can detect soft tissue gas in very advanced stages of necrotizing fasciitis, but has a very poor sensitivity. While lab test imaging tools can aid in the diagnosis, it is essential to recognize they should be viewed as a complementary to clinical judgment, that no diagnostic test should impede or delay surgical intervention. The gold standard method to confirm the diagnosis is surgical exploration. What you see is dual-grade necrotic tissue and fascia, pus resembling dishwasher, and non-contracting muscles, absence of bleeding, and the positive finger test, meaning that tissue can be easily separated with a gloved finger, which is what I found in the OR for this case. Superficial wound swabs are generally discouraged because of the high contaminated risk. Surgery, immediate, extensive surgical removal of necrotic tissue until healthy tissues, such as contractile muscles, glycerin fat, bleeding tissues, are reached. post-op reassessment. We're talking about not just this case. So say if you know, in this case, we went for amputation, but other cases, if it's a soft tissue infection for the abdomen, for the arms, or other part of the body, you don't amputate everything. So the second look surgery to perform additional tissue debridement, averaging sometimes 2 to 3 debridement per patient until all necrotic tissue have been removed and only healthy tissue remain, is usually the way to go. Even with amputation, we don't close those amputation. We at this point, the life over limb, we cut off the limb as quickly as we can. We leave the limb, the bone, muscle, everything open to drainage. So all the infection and the fluid can be drained out. And the plan is to take the patient back for closure down the line when all the infection are gone. IV antibiotics is also the backbone of the treatment. That's all I have. Yeah.
Thank you so much. Thank you so much, Dr. Kang, for that wonderful contribution as well. So moving forward for the rest of the hospital course. So again, we put a side-by-side comparison of what the foot looked like between the initial presentation on the 28th and then the actual day of admission that we're talking about here on the 30th. You can see again more of that violaceous, dusky appearance as well as significant erythema, swelling, and now at this point, frank necrotic tissue and sloughing of that layer. Proceeding forward, so we have here vascular surgery was initially evaluated the patient in the ER the same day as well, and at that time they had recommended no emergent surgical intervention, but to consider future angiogram if the foot was to be deemed salvageable. Later that night at approximately 7:30 in the evening, the patient did spike a fever to a Tmax of 39.2. This event was not reported to the team. And then 5 hours later, the initial blood cultures came back preliminarily positive for gram-positive foci in pairs and chains. Subsequently, 1 hour after that, the PCR results came back positive for group A strep pyogenes. It was at this point in the case that infectious disease consultation was sought, and here to provide that perspective from the ID side is Dr. Paula Lichtenberger. Dr. Lichtenberger is a professor of clinical medicine at the University of Miami Miller School of Medicine, as well as chief of infectious diseases at the Miami VA Medical Center. Her career is centered upon clinical education, antimicrobial stewardship, and global health initiatives. Born in Bogota, Colombia, she completed her medical school at the Universidad El Bosque before completing internal medicine residency at Mount Sinai in Miami, as well as her fellowship here at the University of Miami and Jackson Memorial Hospital. She's published over 50 journal articles in her areas of expertise and played a major role in medical education as both the former program director and subsequent associate program director of the Infectious Diseases Fellowship Program here at the University of Miami. Please join us in welcoming Dr. Lichtenberger to the stage.
Hello, everybody, and thanks again. I kind of like I won the jackpot twice this semester, but I was so excited, and you know that I love when they call me to discuss about cases. So I'm supposed to discuss about antimicrobial treatment, but again, as we mentioned before, when we do M&Ms, and probably those who are old enough like me to be in the era of M&M every month, this was the opportunity to fight against each other and discuss. But the ultimate goal of this is, please don't be that quiet. And this is the ultimate goal, not to judge what was done, but the opportunity to optimize your next patient that comes with signs and symptoms like that. So be fearless about judging, discussing, because this is the opportunity. Everything that happens stays here. But the ultimate goal is not to judge what was done, because we know that you do what you can do when you have the patient in front of you, but to do a little bit something with more evidence tools when you can encounter your next patient. So I'm going to be harsh in trying to do things. I'm going to be harsh, but the whole purpose of this is that at least if you leave this here with 2 different concepts, new concepts that you're going to apply in your practice, I'll be very happy about that one. So that's why I was harsh on the same thing, that every time, and the fellows knows about it, that someone tells me cellulitis and I see an ulcer or a draining, I can kill them. So let's go back to the picture a little bit, because I really want to be emphatic into that. And many of you were actually students of mine, so you know that in medicine does not prevail what you says as a name, but what you describe. So be back to that. Stay aside from guidelines and be back more. How can I describe what I'm seeing? Nowadays, even better because you can take pictures. But from the 28, from the picture that you can send the 28, it gets me so much discomfort when someone, exactly, about that. But if you want to describe, let's go to the guidelines after that picture, okay? Okay, so when we go to that picture and you go to the classification, when you start thinking about necrotizing, you will jumping into choosing antibiotics from narrow spectrum and certain antimicrobials to something more broad and recommending not only antibiotics, but certain type. So when we talk about necrotizing, that's when you start thinking about surgery on board, imaging on board, because especially when you have an eScar, you don't know what is beneath that. You don't know if there's pus, you know if there's a hematoma, do you know if there's ischemia there? So imaging start becoming more important there. Calling surgery becomes very important, and then vascular in the appropriate setting too, because then the differential diagnosis starts that if this is just an infection or we're talking about ischemia. I have a picture here, and before starting, I just want to acknowledge Dr. Alan Bisno. For those who have been long enough, remember him as one of our chief of medicine at the VA and professor of medicine. He was one of the biggest names in the whole country and probably worldwide on group A strep and necrotizing fasciitis. He was part of the guidelines, and most of the literature that was still mentioned right now, including the guidelines that you see, he was the second author for the guidelines. So I just wanted to acknowledge, and my first chapter that I wrote in Up to Date was on necrotizing fasciitis and group A strep with him. So just to acknowledge him, and everybody gets proud, take the name of with one of great authors in group A strep. So when you go to the guidelines, and no brainer, everybody knows. So if you can see that when you have a severe case like this case and you have systemic symptoms and there's no discussion that we're talking about a necrotizing infection, the empiric antibiotics is going to be vancomycin plus piperacillin tazobactam. So let's dissect a little bit further into that recommendation. Can we go to the second one? We have different types of necrotizing fasciitis. For infectious disease purposes, we're going to classify necrotizing fasciitis into 4 big groups. So, and from that, you can have, so that vancomycin, although it's in the guidelines, please take them with a grain of salt, because with that, it's just kind of like the tip of the iceberg of what necrotizing fasciitis. Always remember that when we do the recommendation of vancomycin and piperacillin tazobactam, we're covering the 2 major types of necrotizing fasciitis, that is type 1 and type 2. Type 1 be the polymicrobial, that is most of the time the one that we see in patients with diabetes or patients with GU type of necrotizing fasciitis. So you need to make sure that you're treating the E. coli, you're treating anaerobes, and you're treating streptococcal infections. And in this type of circumstances, you want to make sure in endemic areas of Staphylococcus aureus where you have incidence of more than 20 to 30% to treat Staphylococcus aureus methicillin resistant. Same thing with the type 2, that is exclusively to group A strep, but we're going to talk later about that one. Now, when we talk about type 3 and type 4, and that's very important, an important concept that I want you to learn here in Miami. Remember that we are coastal areas and we have lots of summer here. There are a couple of things that we need to include. One is that we tend to see Vibrio vulnificus here probably once every 5 years or so, but we see it. So we are in Miami, we're in the Caribbean, we have cirrhotic patients, we have immunosuppressed, and oysters and shellfish are a very common culture here. So never forget about asking that in a patient that you're suspicious about necrotizing fasciitis, because that will change the antimicrobial that you were giving. You can give the vancomycin and zosine, but you may switch the zosine for ceftazidime or cefepime, or adding doxycycline or a quinolone to make sure that you are treating the culprit of a type 3 necrotizing fasciitis. And always remember that in this type of infections, you want to hit earlier. So it's not more about going further like meropenem is going at the right track, that is the epidemiological risk factor, like a patient that has liver disease or this or that. And the type 4, that is the fungal, and it's also reminding you that I see a lot of the times physicians adding micafungin to the patient. So micafungin not be the best in the immunocompetent patient, but in the immunocompromised, and when I'm talking about immunocompromised, I'm talking about the neutropenic patient, chemotherapy, chemotherapy and neutropenia, transplant patient, that's when it may come indicated to give the broader spectrum, including antifungals. So that's kind of the general thinking of when to start and what to start. Let's go to the next one. So when we talk about group A streptococcal necrotizing fasciitis, there's a lot of, it's a very dramatic infection because many times when we have the luxury, we have 1 or 2 days, many times we have a couple of hours for this patient to spread the infection. And we have seen cases in which 6, 8 hours, and the patients ended up in big-time surgeries that, are very self-destructive. One important thing is remember, group A streptococcal necrotizing fasciitis can happen to any person. This is not an infection of an immunocompromised state. It's an infection that can happen on any person. And what it happens is that it's depending on the bug, doesn't depend on the host. It has to do with the immunological response that triggers the proteins that they produce the streptococcus. So any person can have it, and as we mentioned, as Dr. Ken mentioned before, 3.5 cases per 100,000. So it's not very common, but when it happens, it's very dramatic because it's the young patient, it's the young mother. So it's a person that all of a sudden ended up from having vacations or having any recent activity to being many times disfigurated by big tap surgery. So group A streptococcal, so you're gonna get surprised that usually the antibiotic, the most important antibiotic we can give is penicillin. So is highly sensitive, and most of the time, beta-lactams prevail as the most important antibiotic. So penicillin is still very active against group A strep. Again, I'm not telling you that once you have a diagnosis of necrotizing fasciitis, you're gonna start the patient on penicillin. No, you're gonna go through the empiric treatment, and when you have the cultures and you have the sensitivities, the ideal antibiotic to start this patient should be penicillin. Remember, if the patient gets worse and you confirm that group A strep, this is not the time to do meropenem or adding it to, what everybody, ceftazidime and meropenem. No, most of the time when a patient with a confirmed group A strep is getting bad is because you need to go to take him to the surgery and do or more debridement or question vascular supply on this patient. But never, the group A strep per se, it's very sensitive. Now, a couple of concepts that I want you to learn from the penicillin and why patients on the right antibiotic don't get better when they have necrotizing fasciitis. One is the concept of eagle effect. And the eagle effect is that very interesting phenomenon that when you have high burden and infection, higher concentrations and do worse than lower concentrations. So now with that, I'm not gonna tell you that you need to give low doses of penicillin or that you have to switch into vancomycin. What the studies have shown is that you have to be very smart in how to address. The explanation for that is that, remember, beta-lactams antibiotics kill via inhibiting the synthesis of the cell wall of the bacteria. So when you have high concentrations of bacteria, a lot of pus, a lot of bacteria around, you have the largest amount of the bacteria are not reproducing very fast. And the very minority are reproducing very, very fast. So, and remember that because of the beta-lactams acts on the cell wall, they will not be effectively killing because the bacteria is not reproducing. So they kill the bacteria that is rapidly reproducing. So one would say like, well, let's do another antibiotic. But again, when it's effective, it's the best antimicrobials, and the studies have shown that beta-lactams are definitely the best killers. So what happened? Through the studies, what they found out is that actually clindamycin is a much better killing because it has that no inoculum effect. And they suppress, on top of that, they will suppress the synthesis of protein and they will facilitate the phagocytosis at subinhibitory doses. So meaning that on top of everything has the post-antibiotic effect. So I'll say like, well, why not to give them only clindamycin? Because it's not as effective as beta-lactams alone. So that's why the studies show that the combination of beta-lactams and clindamycin are the best combination for treating patients with group A strep necrotizing fasciitis. So it's not only the fact that it's decreasing the production, it's actually that it's helping penicillin to do a better job. Okay? Studies show that beta-lactams alone are not as good. Clindamycin alone is not good. The potent compound is both of them. Now, when it's effective? When we make sure that the burden of the infection goes down. So you want to give the combination of treatment for at least 48 hours until the patient is stable. Okay, so just keep that in mind, that it's just not only the toxic, it's just that it's actually really helping. And it has to be the combination of the beta-lactam and the clindamycin. On top of that, hemodynamic effect and the role of the IVIG. I hear a lot about, and there's a lot of discussion all the time about the IVIG. If there's a bacteria that will benefit and is proven with evidence that is proven to have the effect of IVIG, would be group A streptococcal. That's the only one where there's a recent meta-analysis showed that there's an improved mortality at 30 days from 33% to 15%. And again, there's no evidence that in other types of necrotizing fasciitis is useful, and it's only useful when there is severe shock and when there's systemic symptoms. IVIG then will be recommended on a patient who is in the shock, probably in this patient. In the other ones, there's no real recommendation that is going to be evidence-based. And the last one will be, sometimes there is discussed about the prophylaxis on the close contact, meaning penicillin for patients who were or live with that patient and are immunosuppressed or recent surgery. Not evidence-based, but just a point for you to just discuss it when you have patients with family members that are immunosuppressed. That's it.
Thank you. All right. Thank you so much, Dr. Lichtenberger. So just to progress through the rest of the case very briefly, so moving into the hospital day one, vascular surgery did go ahead and recommend emergent OR for guillotine amputation of the right leg. It's important to note that at this point, the patient and the wife had actually declined to provide consent until the patient's wife had physically arrived to the VA. And at this point, infectious diseases had recommended to switch antibiotics to the empiric choice, which is penicillin and clindamycin for the group A strep. And then very subsequently thereafter, the rapid response was called on the patient due to hypotension. Blood pressure at that point was 85/51, which did improve to 91/71 with the initial fluid bolus, but the patient was still tachycardic, and he was alert but in pain. So, he was prepped with pressor support and taken to the OR. In the OR, that's where they had confirmed the necrotizing fasciitis, and they did find that the wound infection had extended proximally, so it required a right through knee amputation. Post-operatively, he was transported to the surgical ICU. At this point, he was intubated on pressors and in critical condition. So his post-op course will take you through January 1st to January 5th. January 1st started to wean drips and ventilation requirements. He was successfully extubated on the following day, January 2nd, but then ended up having a complication, atrial fibrillation with RVR, and he had some pulmonary edema, which prompted us to get an echo, which showed a newly reduced ejection fraction down to 20 to 25%, as well as severe mitral regurg. It was at this point that he was reintubated and reinitiated on pressor support. And then between January 4th and 5th, he started to show signs of mixed shock, as well as multi-organ failure. It was at this point that family did change his code status to DNR. And then subsequently on the 5th, he unfortunately did succumb to the severity of the illness and passed away. So very briefly, this is really just the main timeline. We just wanted to remind you of all of the dates again to kind of keep in mind what the actual timeline was and the progression of events.
Right. So kind of going through our cause and effect diagram here. So we built this, or it's also called a fishbone diagram. We use this to kind of identify it. What we did retrospectively to identify processes or things that could have gone better. So in terms of, for the first part, for the processes, so for the lack of provider continuity between ED visits. So it's, in this case, the patient was seen in the ED on 3 separate occasions, and it was a different ED provider on all 3 occasions, which, had it been, unlikely for it to be the same provider on all 3 visits, but had it been that, it could have been, the severity of the wound could have been more easily identified. And then misaligned thought process and urgency across teams. So vascular surgery and podiatry were both, aware of the case and consulted. And I guess the big picture here is that this severe skin infection was missed, and ultimately the medicine team also it wasn't properly identified by the medicine team as well. So another thing is the trainee hesitation to escalate concerns to attendings. So this is something that I think all of us here we've all maybe struggled with in the past. Had the vascular surgery attending or the podiatry attending seen images of the foot, it may have changed the outcome one way or another. And then for the persistent fevers that were not communicated, I think this is, for someone who's having persistent fevers despite being on antibiotic treatment, it may have led for another opportunity for a physician to, for example, in this case, the resident, to evaluate the patient, which may have led to recognition of the severity of the infection sooner.
And these are facts that are not just unique to this case, but have been shown in studies as well. There's some studies like we indicated here, where there's breakdown of communication and that leads to poor outcomes. So for example, there was a study published in the Journal of American College of Surgery where the #1 area of communication breakdown was the residents notifying the attending when there was a critical event at some point in the perioperative period. Similarly, it's been documented that residents are more likely to act on fevers overnight if they're given instructions or communication about events as they're happening instead of retrospectively finding out.
Thank you. Then for people for diagnostic anchoring. So on multiple notes, for throughout all the ED visits, it said, cellulitis, cellulitis, cellulitis. So, the ED on that third time, I guess, anchored on cellulitis. And I think it's important to, identify that, these biases could lead to potential patient harm. Also, training experience with recognizing NSTI red flags, and then limited after-hour attending supervision. In this case, had this patient been consulted a vascular surgery or podiatry been consulted earlier in the day or in the morning, maybe an attending would have seen the patient and taken to the OR. The patient would have been maybe taken to the OR at that point, which could have potentially changed the outcome. And then delays in optimal empiric antibiotic for NSTI and gas infection. And I guess the last one, which was there was a delay in the consent by the proxy. And then going to equipment, note bloat, like I mentioned before, throughout all the ED provider notes, there was documentation of, cellulitis, and oftentimes when there's so many things in notes, it's tough to miss things, as we may know. So I think that's something to keep in mind. And then two really important things here: the lack of serial wound photos in the EMR, and I think. In some EMRs, it may be easier to do this, like, for example, in Epic versus CPRS. CPRS is, was good at the time it was invented, but now may be a little bit outdated. So had pictures been uploaded into the EMR and people have been able to, physicians have been able to track the photos and seen the progression of the wound, it may have potentially as well changed the outcome. And then finally, for environment, in this case, this happened during the holiday season, and so there were some staffing shortages. Maybe had there been staffing to notify the night relief resident of the fevers, the night relief resident may have been able to see the patient. So these things definitely contributed to the delay in the NSTI recognition and treatment. And I just wanted to leave some time for questions now.
Okay, so open this up. Dr. Lithridge, I don't think everyone heard your last comment.
What I was talking is that it makes a lot of sense to go to the point, but on the other hand, necrotizing fasciitis is such a dramatic process that even if the patient would have everything worked up and done 2 days before, the percentage of mortality of those patients with necrotizing fasciitis is still high. So the outcome could be exactly the same independently if you would act them that day or not, who knows? But
Give to doctor.
Hi, how are you? So I agree, this was my case. We, kept looking back on this case. I do have to say, I agree based on the picture, maybe we if we could have seen or recognized this situation 2 days, the second ER visit, you could argue that he might get away with a ankle disarticulation or a guillotine amputation right above the ankle, because this is what I usually do and what I actually did during the actual operation. He was not intubated. We actually gave him a surgical block because we know by intubating him, when he was hypotensive, already on pressors, with elevated lactate, multi-organ system failure, he's going to crash. So initially, the plan was surgical block, guillotine amputation above the ankle, which is what I did. But afterwards, the dishwasher fluid came out, and I put my finger up, my hand went all the way up to the knee. So I know it's not going to be enough. And then, we're doing the trans knee amputation, but at that point, he couldn't tolerate it under the block. That's when we intubate the patient, and that's when he crashed. He actually coded. He coded 3 times before we, eventually over the next 2 days. And the first code was actually intraoperatively. So I will argue in this situation, to do it, whether overnight, when he came in, actually admitted that night, is already too late. I agree with you. The outcome would have been very similar. But if we 2 days before, on the 28th, when you just started seeing a skin breakdown, might be the chance we can actually save his life, not his limb. Maybe he will actually survive eventually an AK. Will be my prediction.
Thank you. So that I think brings up the point. So just to try to understand and not cast blame, but to understand, he was seen in the ER, and when were the attendings consulted? On the 28th?
Yeah, so just so we can look here at the timeline. So he presented to the ER twice before the presentation that led to admission. So he was seen by vascular only on the presenting admission on the 30th. So on the 28th, when he came in previously, he was seen by podiatry and again treated with outpatient management, but vascular surgery was involved in the case on December 30th.
So an attending podiatrist came and saw the patient in the ED on the 28th and saw this picture, because it wasn't a picture, he actually saw the leg and felt that it was safe to send the patient home at that time. Is that right?
That seems to have been the recommendation at the time.
I think it was the podiatry resident at that time, right? And it wasn't until the attending had seen the patient later on and then had done the addendum to that.
That day?
Yes.
Okay, so but is that day the attending came in and saw the patient? Or the patient just signed the chart?
I think that's the part that wasn't clear, because the attending attestation was timed, very belatedly. So it was, per documentation, it was unclear exactly when the attending had actually seen the patient. And again, there was significant copy forward of exams that may not have been accurate.
And when did your medicine attending see the patient?
So the medicine attending saw the patient the following morning. So on the 31st.
So on the 30th, when he was admitted, the patient was admitted to the emergency room. The house staff went down to see the patient.
Correct.
And there was no attending other than the attending ER physician, presumably who's a boarded ER physician, right? Saw the patient. So it seems as though they should be in the audience as well to understand the consequences of of what they did. Okay. So let me ask you all, your residents, and you treat patients like this all the time. What did you learn from this, and what would you do differently?
So, and I spoke with the resident who was involved from the medicine side, admitting the patient as well. I think one big takeaway, and it was part of our fishbone diagram here, for me personally, this point about misaligned thought process and urgency across teams, because I think, from many different perspectives, the patient appeared very sick, but aligning that together to increase the urgency and not saying, this is necrotizing fasciitis the morning when the patient is now like hypotensive and decompensated, but at least in terms of what can be controlled by the doctors that are seeing this patient on the 30th, We've all pointed out that maybe ultimately the best would have been if had he been admitted on the 28th. But in terms of the team, that saw the patient on the 30th, getting the specialists, the consultants to all discuss and be very specific and sound the alarms. We're concerned that this looks necrotic. We're concerned that this is something that's going to require emergent intervention, like not the next morning, but the night that they're first seeing the patient.
You want to add anything to that, Jose?
I think you did a great job.
Okay, we're at the top of the hour. I want to thank everybody for participating in today's grand rounds. It was a difficult one, but I think a worthwhile one. Remind everybody in the Zoom audience that we don't kill residents ever, and that we want to be sure that you are look for the MOC and CME activities on the chat and on your way out. Take good care of yourselves and see you next week.